I'll be presenting a case of conjunctival lesion which posed us quite a diagnostic dilemma as clinicians because of the age of the patient and the previous history, and where IHC and maybe the histopathology helped us in clinching the diagnosis and maybe deciding the further course of treatment. So it's not changing. Slides. No. Yeah. Okay. So this was a 9-year-old male patient. He was on treatment with us since almost 5 years of age for allergic eye disease. And as we can see here, classically he has this limbitis picture and with classical limbal VKC. And he has been on and off steroids, mast cell stabilizers and multiple lubricants for a period of 4 years. And this is a routine for him, almost seasonally. But this time when he came to us with this clear-cut nodule. He has a well circumscribed lesion of 5 to 6 millimeter. It was not attached to underlying structures, and it was rose Bengal stain negative. And also the patient, because most of these allergy patients keep using steroids on and off by themselves. He had already used it without even our prescription. When he came to us, we thought that one option was maybe it was a foreign body granuloma, but however, the absence of congestion in the surrounding areas ruled this out. And other things that we were keeping in mind was whether it was a benign reactive lymphoid hyperplasia or a lymphoma. That lymphoma, very uncommon at this age, but the classical Salmon patch appearance with corkscrewing of vessels made us think about this diagnosis here. So we also did a AIOC2024 and noticed that there was a very well circumscribed lesion, quite homogeneous. But what was interesting was these dot-like structures here. These are suggestive of maybe activated or reactive lymphocytes. Maybe so that's what made us think it was maybe BRLH. And we decided to proceed with the excision biopsy with cryo and AMG, and intraoperatively it is a homogeneous mass of tissue with no fluid or no cysts involved. So we got our HP reports here. So it suggested again similar to what our clinical diagnosis was, lymphoid hyperplasia, but again not sure of whether it was reactive or atypical. And so we used IHC for further diagnosis. So this was the IHC report. I think Shruti will be discussing it later. So it came as B-cell lymphoma. For clinicians, for us, all this is like Greek and Latin. I cannot make this out. So I have a pathologist at home, who makes it simple for me. So final diagnosis was allergic eye disease with extranodal marginal zone B-cell lymphomas in the left eye. So based on this report, we referred the patient to an oncologist. Patient, when they first went to oncologist, they were suggested to undergo MRI, brain, PET scan, complete evaluation. And based on the reports, they were told to observe every 3 to 6 months. Since it was a child, parents were quite concerned, took him to another oncologist where they were told to repeat the IHC. Here, as opposed to our reports, it showed us Ki-67 index to be low, and so the diagnosis is low-grade marginal lymphoma, and just suggested to be observed, and in case of recurrences, to undergo radiotherapy. Again, they took another opinion. They were just told to observe every 3 months based on the older reports. And later, 1 month later, the patient comes back to us with again congestion bilateral. Patients were very concerned. And this here shows that this is a classical allergic eye disease. This is what I recurred. You can see this limbitis here, diffuse congestion in both the eyes, well scarred area where we operated, and the limbitis. So we just reassured them, put them on allergy treatment, and this time got an allergic workup also. It came out as allergy to dust mites and pollen, gave them slit therapy also, and maybe with steroids it did resolve. But again, once we stopped the steroid, the next day, patient did come back to us with mild subtle congestion. And this time we can notice that there is no limbitis, but there are very subtle lesions in both the eyes. This you can see there's little hypertranslucent areas here, multiple. So this definitely is not allergy. And since we knew this earlier, it was lymphomas, we were suspecting if it has recurred. So the treatment options in front of us were whether he needed repeat excision biopsy. We knew this. We knew that the diagnosis already. So even if we do it again, I don't think we are going to get anything different. And the other option was to observe the patient, and we also explained to them the role of topical treatment like interferons and cyclosporin. And since the oncologist had mentioned about radiotherapy, we also gave the option to them. Also, there are multiple treatment that has been explained in the literature. So when we looked at the literature, when we looked at especially the children with lymphomas, very few reports have been published. Almost maybe 10 or something. With children less than 10, it still narrows down to maybe around 8 or 9 cases. And so that brings us, for a clinician like me, we see multiple, in a day we see around 3 or 4 allergic eye disease, chronic ones. So is this chronic allergic eye disease a stimulus for these patients to develop conjunctival lymphoma? And so it's quite important for us to not treat all these recurrences with congestion as just allergic eye disease, but to look for any other coexisting lesions. And also sometimes these lesions can respond to steroids. So it's more important that any atypical things, we send it for histopathology. And children with conjunctival lymphomas need long-term follow-up and monitoring for systemic lymphomas. Yep. I think Shruti can